Hi, my name is Juan Sardi. I'm a neurosurgery resident from Colombia. We're here today with Dr. Keaveny. It's nice to have you here. How about you tell us a little bit of who you are and what you're doing right now?
Thanks, Juan. So my name is Tony Keaveny. I am a professor of mechanical engineering and bioengineering at UC Berkeley, and I specialize in bone biomechanics and orthopedic biomechanics.
Good. It's really nice to have you here, Dr. Keaveny. You're gonna give us a lecture today. Can you tell us a little bit what's about?
So the main focus of the lecture is how to utilize clinical CT scans for the evaluation of bone quality in spine fusion patients. So we can measure bone density from the scans, and from the biomechanics perspective, we can also get estimates of the bone strength. So how can that be done, and how is it useful clinically?
Jens, thank you very much, and it's a real pleasure to be here and to have this opportunity to present. So the title is fairly self-explanatory. My disclosures, I consult for a lot of drug companies, and I started a company called ON Diagnostics that has developed the technology, some of which I'll present today. So the issue for fusion patients that you want to think about is how do you minimize, in general, how do you minimize failure rates, complication rates? And from a straight scientific perspective, the approach there is to identify the risk factors associated with failure. And then when you apply to an individual patient, you need to be able to measure those risk factors. And if you want to alter clinical outcomes, you've got to be able to change something about those risk factors, or else you're not going to be able to reduce the risk. So my focus, so for example, there may well be risk factors that you know about that you can't change, and you just have to live with that. So from a very practical perspective, you want to zero in on the risk factors that you can change, and then evaluate how much you can change those risk factors and how much will that reduce the risk. You may be able to alter some risk factors that have very low effect on risk, and it's not going to affect your surgical outcome much. So I'm going to focus on risk factors associated with biomechanics. I'm going to even focus more on risk factors today just associated with poor bone quality. There's recent data coming out now establishing that you can reduce the rates of fracture on the adjacent proximal level if you inject PMMA into the adjacent level in a prophylactic fashion. And there are some osteoporosis drug treatments currently available and some in the pipeline being approved by FDA that substantially increase bone strength in a relatively short amount of time and that substantially reduce the risk of having a vertebral fracture. So you have two different effects there. Treatments can reduce risk of fracture regardless of whether you're a fusion patient, and you can do something like a prophylactic vertebroplasty or kyphoplasty and try and stave off a potential proximal junctional fracture. And of course, you can extend the level. You could use maybe screws, special types of screws. There's a number of things you can do to try and avoid failure associated with weak bone. There's also evidence from the osteoporosis world that treatments are more effective in patients at higher risk. And that's not clear whether it's just straight almost statistics, or is it a unique biological effect in higher risk patients. But the higher risk you're at, the more you have to benefit from the risk reduction. It's not clear on the other approaches whether higher risk patients benefit more. So for example, if you do a kyphoplasty or a vertebroplasty in a patient that's at higher risk, it's not clear there'll be a bigger benefit from that kyphoplasty than in another patient. But on the basis that higher risk patients will benefit more from the treatment, then it would make sense to identify patients who have worse bone quality as being the ones that could potentially benefit the most from your intervention. So for example, rather than say I'm going to prophylactically treat every patient with a vertebroplasty in the proximal adjacent level, I'm going to try and identify those who I think will benefit most from that process. Now, in evaluating bone quality, the clinical standard is DEXA, and you should be aware that when it comes to the degenerative spine, DEXA has some severe limitations. One part of DEXA, regardless of degenerative changes, is that in the DEXA signal, since it's an AP projection of the bone, you're including all the posterior elements. And the posterior elements have little relevance at all for the strength of the vertebral body. So there's a large part of the DEXA signal is simply not very relevant. And then you add to that degenerative changes, osteophytes, calcification. That's basically adding bone mass to your measurement. And again, obscuring the real signal that's there. So CT can obviously overcome that being a three-dimensional modality. In addition, the bone biomechanics are interesting in the spine, especially the osteoporotic spine. So based on very detailed work using micro CT scans of cadaver vertebrae, we've been able to tease out what's going on at the micromechanical level in vertebrae. And this is the way we think about what osteoporosis really is. So here's a picture of a vertebral body. You're looking at a thin slice, and the red is the regions of high stress. And what you can see just at a quick glance, there seems to be parallel paths of load transfer from the top to the bottom of the vertebral body. And the way to think about the vertebrae is like a truss structure, and all the individual struts of trabecular bone are little trusses, and you transfer load from the top to the bottom via a contiguous path of these trusses. A simpler way to think of it is the Golden Gate Bridge. If you imagine you've got the main span and the whole thing is held up by the vertical cables, there's about 200 vertical cables. In a well-functioning system, all those vertical cables are sharing the load. Now imagine you start snipping away the vertical cables. Some of them fail, for example. Well, you have 198 other cables to take the load and you hardly notice it. Right, imagine because of osteoporosis, you've lost 50 of those cables. So now we have a much smaller number of cables, and you start snipping away additional cables. Then the situation becomes a lot more precarious, and after a certain point in time, you can't redistribute the load and the whole thing falls apart. So the way we call that structural redundancy in engineering, that you have multiple pathways, so that if any one path fails, the system can continue to function well. So your computers, all the engineering structures around you have structural redundancy built into them. So we think osteoporosis is the point where the bone loses so much bone mass that you have a very small number of load pathways through a vertebra. And then if any part of the remaining bone fails, the whole bone collapses because there's no structural redundancy left anymore. So the bottom line for that is the bone strength is not all about just how much bone you have. And especially when you get towards the osteoporotic vertebra, you need to consider more about the biomechanics. So we have developed abilities to use ordinary CT scans to assess some of that biomechanical behavior. And it was a surprise to us when we did this initial work in the early 2000s that the clinical resolution CT scans actually worked for this, because obviously they don't have the spatial resolution to describe individual trabeculae. But there's enough information there that they pick up the dominant biomechanics. So the idea is you take a CT scan and you generate an engineering structural model out of it, the same way as engineers make models of bridges, and you calibrate the image so you can convert the attenuation data into empirically derived mechanical properties. And then you make this structural model that you can apply virtual forces to, and you can estimate the bone strength. So it looks something like this. You're making your structural model, and then you're virtually compressing it, and then it'll fail. And from that, you can make an estimate of the strength of the bone. So here you can see if you do cadaver experiments and you actually break some vertebrae, that's on the vertical axis, and you compare it with the strength coming off the computer modeling, we call it BCT for biomechanical CT, the correlation is very strong. So essentially, we can on the computer estimate your strength to statistically almost equivalent degree of if you were to take the bone out and crush it. Now, this is crushing the bone under controlled loading conditions. We don't know how exactly your bones are loaded in vivo, but in a standardized system, we can on the computer now simulate what it would be like if we were to crush your bone in the cadaver lab. In clinical studies, these measurements have shown to be better at predicting fracture than just using BMD. So here's results from a study in men. It's called the Miss Ross study. And CT scans and DEXA scans were taken of the men at baseline. They were followed for 5 to 7 years. And those with clinical spine fractures that were confirmed radiographically are shown in red here. And they're compared then against 3 or 4 times as many no fracture controls. There was about 5,000 men in the study at the start. So what you can see is the DEXA BMDs on the horizontal axis, and this vertical line there shows you the cut point for osteoporosis. So everybody on the left-hand line there has spinal osteoporosis, and you can see that you capture quite a few fracture cases in there, not too many white dots in there. The horizontal line on the strength axis shows you the cut point for what we call fragile bone strength. And that tells you who we think has low enough bone strength to give you the same risk of fracture as having osteoporosis. And again, what you can see in the yellow box, these are all the patients that we've identified who fractured, who are missed by DEXA. So patients who have osteopenia who ended up fracturing. So this is a prospective blinded fracture outcome study. We did another study in Iceland. Iceland is one of those Scandinavian countries where they have these captured audiences. This was a study on 5,000 men and women, and it was the same results. The blue here shows you the odds ratios for the bone strength measurements for predicting new vertebral fractures in women or men. The red shows you BMD from a CT scan. We didn't even bother doing DEXA here because, one, it was difficult to do, and it just wasn't fair. So the bone strength is even better than the trabecular BMD. And this summarizes results from 7 or 8 studies on spine fractures. So the red are the odds ratios for bone strength, the black is the odds ratios for DEXA, and then the gray is the BMD coming off CT. In all studies, the bone strength is the highest. Sometimes it's equivalent to the BMD from CT, always better than DEXA. So you can be rest assured that the results we can get from these tests are better than DEXA in assessing who's at risk of fracture. So we've taken that technology and got it cleared by the FDA, and we further adapted it so that in those studies I just showed you, we would use a special external phantom calibration to calibrate the scan. We've developed a phantomless technique where we use your blood and fat and air in the scan to serve as references for calibration purposes, and it works very well. I'm not showing you the data for that, but we've done head-to-head comparisons against DEXA, and you get the same BMD for the hip, for example, as you get from DEXA. And we've done the head-to-head comparisons against quantitative CT with the phantom, and you get almost identical results. So we can use this phantomless calibration on ordinary clinical CT scans. We typically analyze scans that have slice thicknesses anywhere up to about 3 millimeters. We're beginning to do even thicker slices, and you get some reasonable results even from the thicker slices. But it allows us, of course, now to go back retrospectively and look at scans you happen to have in your database and start studying some of your fusion patients. So here's a study out of UCSF with Shane Birch, and we just applied the technique retrospectively to some scans he had for women between 50 and 70 who had had a fusion at UCSF, and who had a CT that showed the L1 or the L2 without any metal hardware. And it worked very well. We were able to analyze all the scans. Here are some results from that. On the left is trabecular BMD measured from CT as a function of age for these women. And on the right is the vertebral strength from the computer modeling. So you're getting both from the test. And the red line there in each case is the cut point for, on the left, osteoporosis, and on the right, what we call this fragile bone strength. And what you can see is a modest number of patients had osteoporosis, but about twice as many patients had the so-called fragile bone strength. And it ended up about 25 or 30% of the women in this cohort we would classify as being at high risk of a vertebral fracture on the basis of the low bone strength. Shane's conclusion from that was that if you're taking CT, then you should do this because you'll get a good assessment of the bone quality. There's really no downside to the patient for that. His interest in that is he has found that using this prophylactic PMMA augmentation is very effective at eliminating proximal junctional fractures, but he doesn't know which patients to apply it to. So he wants an objective method to stratify patients and think about this before surgery and not do it on the fly when he sticks a pedicle screw into your vertebra and realize that there's no bite. He wants to be prepared going in. So we have this test approved by the FDA. It's endorsed by the ISCD. If you have low bone strength or your BMD is low, trabecular BMD is low, the International Society for Clinical Densitometry recommend that's good enough to decide to treat. And the way we offer this service now is that you send us the CT scan and we send you back a medical report the next day. So that's what we're trying to implement. Some caveats with this is that you're working off clinical resolution CT scans. So we cannot see anything at the molecular level. We cannot tell you from a CT scan if this patient has osteomalacia. So although I might refer to this here as bone quality, it's not that quality. It's not the molecular level quality. And you just have to keep that in mind. We don't have, in these clinical CT scans, excellent resolution of the thin cortices. But as I mentioned, it seems that the resolution is sufficient still to provide pretty accurate data on strength. We haven't proven in any studies that, for example, if you were to treat these patients, say with Forteo, that the change in bone strength translates into a certain reduction in risk. We haven't been able to quantify that. So the assumption is that increasing bone strength reduces risk. I think that's a very reasonable assumption, but no one has put numbers on that. X% change in bone strength causes Y% risk reduction. That's work in progress. We're using standardized loading conditions. We are investigating different types of loading conditions to see if it provides any extra useful information, but so far it doesn't seem to, probably because the bone responds fairly similarly to different types of loading conditions. And we don't have soft tissues in here, so there's no muscles, there's no ligaments. In the models, the results I showed you, there's not even the disc, although we are beginning to get into that. And of course, for spine patients, the disc is a lot of fun. This gives you an idea of what we're currently doing. So we can virtually implant pedicle screws now and constructs and start looking at the stresses around the pedicle screws. It's interesting when you do this and you load the bone, you get anterior. If you don't have the pedicle screw in there and you load the bone, and the bone's bending forward like this, you get a very slight anterior shift of stress in the disc. But when you stick the pedicle screw in there, in some patients, the load on the disc shifts way forward. And what's happening is you're getting distal load transfer out of the end of the screw, which is completely non-physiological, which overloads the disc. And that may be one of the reasons why you're getting this proximal junctional fracture and kyphosis. So this is ongoing work. We're doing lots of interesting things. How can we go to the next level on this? We can measure all sorts of things now, especially when you stick in pedicle screws. And we are beginning to conduct, and we want to talk to Dr. Chapman about potentially collaborating here. We want to identify what are the measurements that most predict clinical success or failure. Could you imagine doing a battery of these simulations on your patient from a CT and getting a sense for risk of certain types of failure modes? That will require a prospective observational study. We've tried to work with retrospective data. It's not good enough. People aren't recording the information the way you wanted. What we'd like to do is design a prospective observational study where we take the CT scan, then you go ahead and treat your patient, and we try and predict whether or not the failure will have some negative outcomes, and from that try and figure out what's working best. Of course, being very practical, you're only interested in measurements that you can change, right? If I can't change the risk factor in a sense, it's almost academic. So we want to be very focused on putting our finger on the things we can change with your surgical plan or with drug treatment, because that's the only thing that's going to affect the clinical outcomes. An interesting conceptual issue is, in the drug world, it's obvious you want randomized controlled trials to show efficacy. My experience is that's almost impossible in orthopedics. I would be surprised if any of you would offer your patient option A versus option B when you've got lingering doubts about A versus B. You want to do the best thing for your patient. I can't imagine if I was having a fusion surgery, I'd want to sign up for a research study. Very few people are going to want to do that. So the challenge is, what is the level of clinical evidence you would want as the person who's really running this, in order to decide to adopt any of these kinds of approaches, as opposed to just going with your current approaches. So I think that's an interesting conceptual issue for the field. If you leave it to the public health folks, they will demand evidence-based data on the level of a drug trial. And I think in orthopedics, that's almost impossible. If you demand that, you're basically saying, let's not change anything. I'm not defending not having evidence, but it's an interesting issue. So in conclusion, currently today, we can do these biomechanical analysis on your pre-existing CT scans. You can then use the bone density and the bone strength information to decide whether or not this patient has poor bone quality. And you can be rest assured that this is as good as you're going to get currently clinically in assessing the bone. And it's ready to go clinically. The challenge is logistically just trying to get it into the flow of things. And hopefully that'll help you better prepare yourself for your surgeries. Thank you very much.
So it was a really interesting lecture you just gave. I have a couple of questions actually regarding some of the issues you talked about. First of all, have you studied like each of the different segments separately? Like, have you ever encountered any differences regarding the distribution of the loads in the cervical spine with regard to the thoracic spine, with regard to the lumbar spine?
Yeah. So we haven't looked much at the cervical spine. Most of the cases we've analyzed so far have been thoracic or lumbar spine. And it's a little bit of a challenge, because if I measure bone density or bone strength at different vertebral levels, the bone size is different. So your T4 versus your L4, very different. And to interpret those data, you have to know something about what's important clinically for these different levels. So that actually is a unique issue. In the osteoporosis world, we just focus on the lumbar spine, and all the clinical outcome studies are based on measurements at the lumbar spine. So what we've had to do along the way then is understand what's the relationship between the strength, say at T4, T5, versus the strength lower downs, so we can relate what we know about fracture thresholds at the lower levels up to the upper levels. So what you find is there are relations between them. There's a reasonably good correlation, but there is a fair amount of scatter. So it raises the question for evaluation of fusion patients. Is it important to just get an analysis at say one standardized level, or do you need to look at every single level and see, are there particular weak spots along the spine that the surgeon would present? The only reason not to do the latter is if you're basing it on a CT scan, you have to take a CT scan of the whole spine, which is more radiation than just a few levels. And there's obviously a little bit more effort in the analysis side. So but it's mostly the concern about the radiation, why you wouldn't do multiple levels. So because of that, we don't quite know the value of doing multiple different levels as opposed to just picking one or two levels.
Okay. Have you started testing this on patients? I mean, like, have you gotten the CT scans of a patient with a fracture, analyzed the loads or the bone density, and then applied that to the surgical procedure that he's receiving? I mean, have you ever changed the conduct or taken different conducts based on the findings?
Right. So the technique at this point in time, it's fairly early stage for application to prediction of spine fusion outcomes. So what we can say fairly confidently at this point is we can assess whether or not the patient has poor bone quality or not.
Okay.
That's well validated in observational fracture outcome studies, nothing to do with fusion. The question now is, can these measurements predict an outcome for a particular patient? And that, we're just in the middle of doing that. So the early results, which I did not present today, but the early results suggest that the bone strength gives you definitely more information than the bone density. There is a real distinction there. But we haven't gotten into some of the more exotic measurements that we're now beginning to make. But that's the holy grail. You know, can we, for a patient who comes in the door, can we actually put them in a risk category? You are at high risk of failure, and then simulate different surgical options, and then from that choose the option that would reduce their risk the most. That's where we want to go. We're not there yet. So at this point, the test will just the test will help the surgeon determine the state of the patient's bone, which is definitely an advance over where things are right now. But that's just really the first step in where we want to go with this longer term.
Okay. Another thing I really found interesting was the little video you showed us regarding the loads the vertebrae receive when you put a transpedicular screw in them. Which is actually kind of amazing because they're not physiological at all from what we saw. But regardless of that, that's like still one of the most used methods right now to correct spine fractures or to treat scoliosis. Can you think maybe that will lead to a change in the way we treat fractures or other techniques that we have to start implementing?
Yeah, I think certainly when you begin to see the stress patterns that develop around, for example, a pedicle screw, you immediately realize they're non-physiological, right? Normally, stress doesn't come through the disc and then out through the posterior elements. Normally the stress comes from the disc through the vertebral body down to the lower disc. So it's very, very strange loading for the bone. The same can be said for a hip joint. If you look at a natural hip joint versus an artificial hip joint. With the artificial hip joint, the force is coming through the metallic stem, the head down into the stem, and then it's transferred out to the cortical diaphysis, which is non-physiological. So just because it's non-physiological doesn't mean it's not going to work. And I think the difference, though, between the spine and the hip is the hip bone, that cortical diaphysis is very strong, and it can take high level of stress. I think the challenge with the spine is that there's probably a subset of patients where this is not going to work. And so we are finally in a position where we can investigate that. But my sense is that's the way it's going to be. For many patients, it's going to be okay, even though it's not physiological. But there will be a subset of patients where if, for whatever reason, the bone geometry is not quite right, the bone density is not quite right, that the system will never adapt to it and stabilize. Now, for that situation, I think we have to think about alternative solutions. And maybe this work will give us insight into what are some of the possibilities. Right now, people are trying artificial discs, and that area is really just in its infancy as well. But if I was to wave a magic wand, that's what I'd want. I'd want an artificial disc that maintains the more natural load transfer mechanisms. But the challenge there is fixing that disc to the bone. That's not a trivial problem.
Because from past studies, we have Wolff's law, which actually dictates that the bone will develop or will grow according to the loads that it receives. So do you think it maybe in a future or not so distant future, we can treat patients like redistributing the loads and not implement like these invasive constructs or like alternative strategies, I guess, that might actually put an advantage to the loads that we give the patient in order to heal fractures or heal?
That's, when you think about a spine fusion and you have bone in the disc space, you are invoking Wolff's law to turn that bone graft into an integrated bone-to-bone bridging right between the vertebrae. So I think, and orthopedics is full of those kinds of stories. So that's definitely a possibility. The problem, of course, is if you do that multiple levels, you've no motion left for those levels, and you're potentially pushing problems upstairs, right to the proximal junction. But Wolff's law is an interesting one that you mentioned, because it could well be that even with a pedicle screw, there's a positive Wolff's law adaptation, and that pedicle screw posterior, rods, becomes a stable configuration. In other words, the bone adapts, and this is the new status quo, and it works. So the challenge always is can you get it to work in everybody, versus is there a subset of patients where you feel it's not going to work, right? So again, a lot of this comes back to better understanding the biomechanical options, and also tying that in with tests you might be able to do up front as part of the surgical planning that'll help you choose what the best procedure might be for some patients. Because the posterior fixation, that works for many patients, so you're not just going to throw it away. So there's definitely value there.
We're taking a question right now from our Facebook page. We want to know if there's a way to make BMP more successful in clinical uses.
So I'm only going to speculate on this, but from the biomechanics perspective, one of the issues here is that the BMP can have a relatively short-term anabolic effect. So imagine a scenario where it produces a lot of new bone tissue. Then biomechanically, if that bone tissue doesn't take much load, then once the BMP has been used up, there's a good chance that bone will just resorb away. And in that case, you're back to square one, where you had where the BMP might as well not have existed. So it might well be that BMP is most effective when used in locations that once you put bone there, they become functioning load-bearing bone. And so maybe a way to optimize BMP is to know where to put it, precisely where to put it, and so that's how I'd kind of tied in with the biomechanics.
Okay. I think we're done for today. Thank you very much, Dr.
Yeah, my pleasure.
Keaveny. It was a pleasure having you here. Thank you very much.
Thank you.